Well, good evening, everyone. Thank you for attending the Public Health Grand Rounds, sponsored by the Public Health and Preventive Medicine section of the College of Physicians of Philadelphia. I'm very excited about the Grand Rounds this evening on preventing sleep-related deaths, a leading cause of post-neonatal mortality in Philadelphia. I'm Michael Halpern. I'm a faculty member in the Temple University College of Public Health and a member of the Preventive Medicine and Public Health section of the college. So just as some background, the Philadelphia Public Health Grand Rounds, our purpose in holding these Grand Rounds is to address important public health issues in the Philadelphia region. To do this, we bring in local speakers who come from a wide range of disciplines and perspectives. The overall goal is to generate new ideas and collaborations and to help strengthen the Philadelphia-based public health community. Co-sponsors of the Grand Rounds include the College of Physicians and the Philadelphia Department of Public Health. We'd also like to acknowledge and thank the Thomas Skelton Harrison Foundation for their generous contribution. So please, during this process, which will last about an hour and a half, there will be 3 presentations, which will total to about 1 hour, followed by some question and answer period that'll be about half an hour. So please, following the presentations, participate in the question and answer section. We look forward to your questions and comments. There are evaluation forms that everyone should have received when they checked in. If not, there are extras, I believe, on the table outside. Please complete those and turn those in at the end of the Grand Rounds. Outside, there's also volunteer and membership forms. You do not need to be a member of the College of Physicians to join the Public Health and Preventive Medicine section, and I encourage everyone to join the section. We will also be having a reception afterwards, so we hope that you will stay for this social event, which will be held in the room next door. I'd also like to alert you to the upcoming Public Health Grand Rounds. So we have 2 scheduled in the spring. Both are held, as is this one, on Wednesdays at 5:30 p.m. On February 28th, there will be a Public Health Grand Rounds on gun violence and public health. And then on May 16th, on obesity and its prevention in Philadelphia. I'd like to now introduce the moderator for this evening. I'm very pleased that Dr. Eileen Tyrala has agreed to serve as the moderator. Dr. Tyrala is a professor of pediatrics at Drexel University College of Medicine and has served as the director of neonatology at Temple University Hospital and of the neonatal intensive care unit at St. Christopher's Hospital for Children. She is currently practicing general pediatrics in Philadelphia. Since 2003, Dr. Tyrala has been the medical director for Cribs for Kids, a national organization that promotes infant safe sleep education and provides the gift of a crib to all families in need. She was instrumental in the successful passage of the Act in 2010, which mandated that all maternity centers in Pennsylvania provide education to new families on how to protect their infants from sleep-related death. She is currently a member of the Pennsylvania AAP's Infant Safe Sleep Committee and of the Philadelphia Fetal Infant Mortality Review Team. With that, please welcome Dr. Tyrala.
Thank you all very much. Everybody, just remember to turn off your cell phones. Okay. Sleep-related infant deaths, as Dr. Halpern said, are the 3rd most common cause of infant mortality, not only here in Philadelphia, but in the United States, only exceeded by prematurity and congenital abnormalities. Prior to the last 20 years, the vast majority of sleep-related infant deaths were called SIDS deaths. SIDS deaths are deaths that occur in infants under 1 year of age, that after an autopsy, a complete review of the circumstances of the death and the medical history of the baby, that absolutely no cause for the death can be found. The 1994 Back to Sleep campaign, which urged all parents to put their infants to sleep on their backs, decreased the incidence of deaths that we called SIDS deaths by over 50% in a 6-year time period. Indeed, the Back to Sleep campaign has been and still stands as one of the most successful public health campaigns that has ever occurred in the United States. In 1996, new protocols for the investigation of infant deaths were issued by the Center for Disease Control, which called for more in-depth questioning and probing of the circumstances of infant deaths. This resulted in something called a coding diagnostic shift, away from calling sleep-related deaths SIDS, or completely mysterious and inexplicable, towards accidental suffocation and asphyxia and strangulation in bed, and undetermined. An undetermined death was a death where an infant could have been found in what would have been considered an unsafe sleep environment, but it could not be proof positive that the baby had actually succumbed to a suffocation death. Indeed, accidental suffocation and strangulation in bed is considered to be the most common cause of preventable death in infants under 1 year of age, accounting for about 2/3 of them. Our program this evening will explore the realities of sleep-related infant deaths as they occur here in Philadelphia. Our first speaker is Dr. Roy Hoffman, who is the medical director of the Fatality Review Team for the Medical Examiner's Office of Philadelphia and of the Philadelphia Department of Health. Dr. Hoffman will present Philadelphia's data. He will be followed by Dr. Esther Chung, who is the medical director of the newborn nurseries at Thomas Jefferson University Hospital. She will speak about the role of birthing hospitals and pediatricians in the city in promoting the infant safe sleep message. Our third speaker is Dr. Sara Kinsman. She is the Director of Maternal, Child, and Family Health for the Philadelphia Department of Health, and she will discuss the Health Department's launch of same room, different beds, we all sleep better. The story behind Safe Sleep Philly. Okay. Dr. Hoffman.
Thank you. It's a pleasure to be here to talk to everyone tonight. In the next 15 minutes, I'm going to give a talk. I'm going to tell you very briefly about the history of child death review. I'm going to give a little bit of background about some key definitions and terms, and then I'm going to spend the last bit of time giving you some data about some numbers from a report we had about 2011 to 2015 sleep-related infant deaths here in Philadelphia. And I'm speaking to you here today as a topic that's also important to me. I speak as a public health practitioner. I speak as a practicing pediatrician at Health Center number 6, and also as the father of 3 young children, including identical twin boys. So sleep environment, very important topic to me and to everyone here in Philadelphia. So first, this one slide to give you a brief overview about child death review. The purpose of child death review, which is what my team does, is to get a better understanding about the circumstances surrounding a child's death. Our teams don't do autopsies. That's the cause and manner of death is determined by either the primary physician or a pathologist. Our teams look at the circumstances surrounding the deaths. The goal is to identify shortfalls or gaps in our services and community resources. And ultimately, what we hope to do is to make recommendations, and hopefully data-driven recommendations, to improve the well-being of children here in Philadelphia and prevent future child deaths. A little quick snapshot about the history of child death review in the United States. This is a relatively new thing. About 3 counties started in the late 1970s, these child death review teams. The original purpose was to look for possible suspicious deaths. They were trying to make sure they caught deaths that were due to abuse and neglect that were otherwise being missed. Over the years, especially in the 1990s, it started to spread to many different states across the country, and up until today, when now every single state and territory has its own child death review process, whether at the state or local level. Most states nowadays have a mandate to do child death review, and Pennsylvania actually passed a law in 2008. And on top of all that, there's a national child death review database that is used by 45 states in the country. The other 5 don't use it because they have their own state-based databases. And as a matter of fact, from what I learned before this presentation, there have been almost 200,000 cases entered into this national database since it started in 2005. And Philadelphia, which was a starting member of that group, has entered about 5% of the overall cases in the country. So a little bit now about the history of child death review in Philadelphia. As a county, we've been doing child death review since 1993, before there was any mandate. We have both a homicide and a separate non-homicide team. We review the deaths of any Philadelphia residents from birth through the age of 21. We go up through age 21 because that's part of Pennsylvania's mandates. Most states go through age 17, some do 18. Pennsylvania might be the only state that goes to age 21. The death review team is run by my unit, the Fatality Review Program, which is housed in the Medical Examiner's Office, which is a part of the Philadelphia Department of Public Health. A separate type of child death review team called FEMUR, or Fetal Infant Mortality Review, is performed at the Maternal, Child, and Family Health Division, and Dr. Kinsman will talk a little bit more about FEMUR during her presentation. So now I want to talk to you about some key definitions, and I apologize in advance because there are several different definitions out there. Some of them you may know. Some of them are actually used interchangeably, even by people in the public health field. And so I don't want to get too nitty-gritty, but I'm going to go over some of the definitions that we're going to be using for the most part in this presentation. And so SUID is an acronym which stands for Sudden Unexpected Infant Death. The death of an infant, which means, in this case, we mean someone younger than 1 year of age, that occurs suddenly and unexpectedly, whose cause of death is not immediately obvious before an investigation occurs. SUID is a broad category of deaths. It's not a cause of death. SUID cases should elicit an investigation and autopsy by the medical examiner's or coroner's office. And SUID is really not the same thing as SIDS. SIDS stands for Sudden Infant Death Syndrome, which is a cause of death. And I can tell you also, even the American Academy of Pediatrics and national level and NICHD, they oftentimes, I find them using SIDS for what I would call sleep-related deaths. And I don't want to confuse you, but just to try to keep things straight, how we're presenting things here today. So if a child or infant dies suddenly and unexpectedly, like I said, that will elicit, especially here in Philadelphia, it will elicit a full investigation and an autopsy. So some of the possible outcomes of that investigation could be child abuse or neglect. And that's the one thing that all of us worry most about. We want to make sure we never miss a case of child abuse or neglect. An infant who dies a SUID death could be due to an accidental poisoning, an accidental ingestion. After investigation, we find out it might be due to an infectious process, such as influenza or pertussis. It could also be due to a congenital anomaly that wasn't at first recognized. There's also the basket of all others. But the 3 main things I'm going to talk to you about moving forward are SIDS, accidental suffocation, and unknown or undetermined. So these 3 categories of death, causes of death, is what we typically refer to as sleep-related infant deaths, and that's the basis of our talk today. So SIDS, the exact definition what Dr. Tyrala already gave to you, is a sudden death of an infant less than 1 year that cannot be explained after a thorough investigation is conducted, including a complete autopsy, examination, and a review of the clinical history. Accidental suffocation, or sometimes more technically referred to in the public health literature as ASSB, or accidental suffocation and strangulation in bed. It can be due to suffocation. For example, a pillow or heavy blankets pressed up against the nose or mouth of an infant. Overlay, where another person or even an animal could roll over onto a sleeping infant. Wedging or entrapment. For example, an infant crawls off the bed and falls between the bed mattress and a wall. And strangulation, for example, like a blanket or something gets wrapped around a baby's neck and strangulates them. Finally, there's undetermined or unknown. It's a very unsatisfying diagnosis to families when their infant has died, but sometimes after everything, after a full autopsy and investigation, they still don't know. Anecdotally, there's no direct rules from medical examiner to medical examiner, but oftentimes SIDS denotes an infant that has died in a safe sleep environment. Accidental suffocation is where they feel that the baby has definitely suffocated, and sometimes the undetermined is somewhere in between, where they can't be certain that it was SIDS, but they don't feel confident enough to call it a suffocation, or so they'll call it undetermined. And those tend to be about half of our cases in general. So now I'm going to talk about how sleep-related infant deaths compare to other major killers of children in Philadelphia. And when I say children, I'm referring to those 17 and under. So I'm going to show a bunch of different major topics, categories of death, and tell you how it compares to sleep-related deaths. So first I have motor vehicle crashes. Thankfully those occur much less often, but much rarer than sleep-related infant deaths. Fire deaths are actually quite uncommon in Philadelphia, thankfully. As a matter of fact, in 2015, there was not a single child death due to fire. Cardiomyopathy is exceedingly rare. Prematurity or other perinatal issues, as Dr. Tyrala mentioned in her introduction, that is by far the leading killer of infants and also of children in Philadelphia. Meningitis, thankfully that's exceedingly rare, much less common. Choking, exceedingly rare in Philadelphia. Drug overdose, we've all heard about the opioid epidemic that has gripped Philadelphia and the rest of the nation. Up until today, it still hasn't gotten through to the child population in Philadelphia, so we haven't seen quite yet a bump in numbers, and thankfully they're still quite rare in Philadelphia for Philadelphia children. Congenital anomalies, actually that's about the same as sleep-related infant deaths in Philadelphia. I know on a nationwide level it happens more often, but in Philadelphia we actually have slightly more sleep-related deaths, or have had historically, than congenital anomalies. Drowning is exceedingly rare. Anaphylaxis, since I've been doing my job since 2009, I haven't learned of a single case of a Philadelphia child who has died due to anaphylaxis, thankfully. Asthma is quite rare. Homicide, including child abuse and neglect, is a fairly high number of child deaths, but still less than sleep-related infant deaths. Cancer is a lot less than sleep-related infant deaths. Suicide, thankfully quite rare in Philadelphia children. And then all these other things I put up here: ruptured aneurysm, appendicitis, HIV, sickle cell disease, carbon monoxide poisoning falls, all quite rare for causes of infant death. So when I show you all of these causes of death combined, and I take away prematurity, congenital anomalies, and homicides, all of these combined, all of these categories combined, equal on an annual basis, on average, about the same number as sleep-related infant deaths in Philadelphia. I looked at a 12-year period and added up the numbers, and all of these combined come out to about the same on an annual basis. So when an infant dies suddenly and unexpectedly, there's a process that we go through. First, the hospital or a first responder will notify the medical examiner's office about the death. The MEO investigator will then go to the scene. They'll interview the parents. They'll do a scene reenactment. They'll take photographs, and sometimes they collect evidence, like anything formula left in a bottle. We test those for toxicology, just in case. The MEO investigator will gather additional information, getting records from hospitals, primary care physicians, the police or special victims unit, and others. And then an MEO forensic pathologist will complete a full autopsy, which includes toxicology, histology, microbiology, a metabolic panel, neuropathology, and if necessary, chemistry. As you can see, this is a very complete process. We do this for every single sudden unexpected infant death. And just so you know, typically it takes about 10 to 12 weeks for a case to be finalized, or what we call it is unpended, for the final cause of death. Beyond this full investigation, there's a lot more that's done behind the scenes. An MEO investigator will notify a DHS hotline about every single case that occurs. The FAAP medical director, or me, will notify the law department and DHS about each case through what we call a CERT email. We have social workers at the medical examiner's office whose job is to do reach out to these families and offer them free bereavement in their own home. Our child death review team reviews each case, typically within 3 to 4 months of the death. And on rare occasion, we will notify the Consumer Product Safety Commission. And for example, several years ago, we were reviewing a sudden unexpected infant death of a baby in this type of sling, an Infantino sling. We notified a Consumer Product Safety Commission. There were some other people who notified across the country. They had a recall of this thing. And then finally, I will nominate select cases to be further reviewed by the Fetal Infant Mortality Review Team. And again, Dr. Kinsman will talk about the FEMUR team in her presentation. These next 5 slides, these final 5 slides, are going to show some data we have of 2011 to 2015 sudden sleep-related infant deaths. This was put together in a chart report. The chart reports, by the way, if you don't know, can be found on the Health Commissioner's website. They're open to the entire public. People can sign up, subscribe for getting emails. There's been about 15 chart reports since they were started. And so here we see all these graphs come from that report. So here are the total number of sleep-related infant deaths going back to 2005. And it might not be that obvious, but the number is actually declining. If you look at from 2005 to 2012, we averaged in Philadelphia about 43 to 44 sleep-related infant deaths every year. However, from 2013 to the present, it doesn't include 2016 data, which you can't see, but I know about those numbers have decreased to an average of about 28 to 29 per year, which in some ways is fantastic. We've decreased it they have been decreased by a third, but there's still quite a ways to go. As you can see here, the infants that die of these sleep-related infant deaths tend to be younger. About 90% of them are less than 6 months of age, with a peak at about 1 to 2 months of age. And probably a lot of the reason for why this happens less frequently as they get older is as the infants develop their motor skills, they can free their necks and heads out of possibly suffocating situations. The deaths of our sleep-related infant deaths are not distributed proportionally through our racial and ethnic groups. As you can see here, based on per 1,000 live births, Black non-Hispanic infants die at over 3 times the rate of white non-Hispanic infants, sleep-related infant deaths here in Philadelphia. And the disproportion is not limited to race and ethnicity, but also to socioeconomics. Almost half of our cases of sleep-related infant deaths happen in the neighborhoods of the lowest quartile incomes, while less than 10% of our deaths happen in neighborhoods of the highest quartile of incomes. And finally, this is a slide that Dr. Kinsman will also have in her presentation, but you can see here some of the modifiable risk factors for sleep-related infant deaths. Sleep place, 70% of the infants were not in a safe sleep place at the time that they died, and we consider a safe sleep place to be a bassinet, a crib, or a pack and play. Over half of them admitted to sleeping with someone else or co-sleeping at the time of death. And almost half of them, looking at the bottom left, had clutter. Even if they were placed in a safe place to sleep, they had clutter in that crib, pack and play, or bassinet, such as baby bumpers, thick blankets, stuffed animals, adult pillows. So in summary for my talk, I want to just reemphasize again that sleep-related infant deaths refers to the deaths of infants less than a year of age while sleeping and due either to SIDS, accidental suffocation, or undetermined causes. Sleep-related infant deaths is one of, by far, the largest killers of Philadelphia children, only really surpassed by prematurity. There are large racial and socioeconomic disparities among our sleep-related infant deaths. Some good news is that sleep-related deaths have been decreasing in Philadelphia, but as I mentioned, there's still a ways to go. And finally, the last take-home message for everyone here in the audience is that most sleep-related infant deaths are preventable, which is why we're talking about it. There are actions that systems can take, that agencies can take, that providers, students, families can take in order to further reduce our risk of sleep-related infant deaths. Thank you.
Good evening. Can you all hear me? Is mic working? No. How about now? Better? Okay. Well, I want to thank everybody for being here. I'm really excited to see such a large audience for a very important public health topic. How many of you are going to be in Atlanta at the American Public Health Association meetings? Hopefully that number will increase. I'll see you there. Okay, today I'm going to be talking about infant health disparities, kind of to build on some of the information that Dr. Hoffman gave you, and to talk about bridging the gap between some of the disparities by using simple messages and what hospitals can do to promote those messages. So here's an overview of my brief portion of the talk. First, to talk about the disparities in SIDS risk, and a lot of us talk about SIDS risk reduction rather than SIDS prevention, some of the nomenclature that we kind of use, the role of hospitals, and using simple messages. Many of you are familiar with the Healthy People goals, and I'm happy to say that Healthy People 2020, which will soon be revised and be Healthy People 2030, that's kind of scary. So for the MICH goals, it's to reduce the rate of infant deaths, and then for infant care, to increase the proportion of infants who are put to sleep on their backs. And I think the emphasis for the back sleep position really has been because many people consider it to be the #1 modifiable risk factor to reduce SIDS. This slide shows you health disparities across our nation, and if you take a look, the various bar graphs, I'll give you a little bit of time to get oriented. The blue bar represents whites, the red bar blacks, the green bar American Indians, Alaska Natives, Asians, and Hispanics, and you can see that overwhelmingly across the years there is a race ethnic health disparity. Now, many of us consider this to be a social injustice, and there are lots of opportunities for advocacy that we can talk offline about, but this is a disgrace. It should not be happening in our country, and it should stop. I'm happy to say that you can see through the graph that there have been declines in SIDS rates, and this does include SUID. You can see by the reference up there. But the health disparity, we really have to narrow that gap. So whatever you all can do in the power in your jobs and, talking to friends, doing advocacy in your workplaces, I think we all play a role. This slide shows U.S. trends in SIDS rates and prone positioning by race ethnicity. And again, it reiterates that there are health disparities. But what I want to point out in this slide is that you can see that the prone position for each race trends with SIDS cases. Okay? There's so much convincing evidence about sleep position and its impact on SIDS. And I suggest that if you haven't read the literature, that you go to read the literature. Very, very striking and repeated in many studies. The other thing that this slide shows is that we have had overall reductions in SIDS rates and the use of the prone sleep position. And I'm going to show that in some of my personal and professional slides as well, and that's great news. So public health works, health messaging works, and all of your great work is effective, in case you were wondering. Okay, this slide shows some summary data from a study that I did many years ago with colleagues in California when I was at UCSF. And we looked at PRAMS data. Many of you are familiar with that data. And you can see that over 3,000 cases that we looked at, and we looked at the association between back sleep position and various factors. And what this slide, again, reiterates is that African American race ethnicity had half the likelihood of using the back sleep position. Okay? Again, that is not something that should be happening, and definitely something that we could work on. The other thing that this slide shows relates to disparities, and Dr. Hoffman touched on some of these, related to education, income, and being non-English speaking. And I think many of you know that we have growing rates of people coming from other countries, whether they're refugees or immigrants, and that we have to kind of make our health information accessible to all people who live in our country. I hope this is not too confusing for many of you, but the odds ratios are kind of less than 1, and this relates to the back sleep position. And this is showing a lower odds ratio or lower likelihood of using the back sleep position by the risk factor that's shown. This slide is a study that we did just at our hospital, thanks to a medical student who took interest in this topic. And she basically, along with the nurses, surveyed new mothers 2 to 4 weeks postpartum to see what some of their attitudes were related to SIDS risks. And we were curious to know, when do new parents get information? And I'm happy to say that about 35% got the information during pregnancy. That means our OB colleagues are doing a fabulous job at talking about SIDS risk reduction. I'm also, though I'm happy, I'm also sad because that's only 35%, and I would love to see that number be bigger. So the majority of people are still getting the information postpartum. Now, is that a little late? Because people are pregnant for about 9 months, and they have time to think about all sorts of things. The products they're buying. There are lots of products on the market that relate to sleep. Not all of them have been safety tested or approved by the Consumer Product Safety Commission, and many of them are really, really cool looking, and they're decorative, and people want to do right by their children, and they want to make the room beautiful and accessible, and they want comments from friends and relatives, but we want to keep everybody safe. So if all this information is happening after the baby's born, where's that information happening? There's a lot of pressure on us as newborn providers to talk to families within the first 36 hours before their discharge on day of life 2. And there's a lot of information coming at families, and so this is hard. And so how can we keep the message, how can we make them simple and accessible, and how can we have the message be repeated over and over again, starting with pregnancy? I'm going to use this mic if that's okay with everybody. All right. The other thing is I don't know how many of you have pretended to be pregnant through Text for Babies. I've been pregnant 3 times with Text for Babies and twice in real life. That gives me 5 pregnancies. But Text for Babies has important messages that come through text messages. If you're interested, it's 511-411. You can sign up right now as I'm talking, but please do that after I finish talking. They do have messages about safe sleep. Do they have enough messages? I don't know. I'd have to track it and kind of take a look. There are so many messages that they feel the need to get out. But it's a very innovative way of communicating with pregnant women. Okay, this slide is from the same study, and we looked at SIDS risks and parent beliefs and knowledge. And I'm very, very happy to say that the large majority knew that the back sleep position was the safest. So the message has come across. The majority also knew that there was an increased risk of SIDS by having the baby sleep on a sofa. Other great news. The sad, frowny face news is that the risk of choking on the back seems to be a confusing message that parents are largely uncertain about. And they're scared. And because they're scared, many of them feel that it's safer to put their babies prone or on the stomachs, because it seems like common sense that if they were to vomit, then it would come out on the mattress and it would not kind of get inhaled or kind of cause their baby to have any risk for breathing. I'm very concerned about this issue, and I think that we as providers need to continue to have messaging that relates to some of the fears and uncertainties that families have. This next slide shows risk factors associated with bed sharing. Now, I'm very specific when I call it bed sharing because some people think of co-sleeping as sleeping in the same room, but bed sharing is specifically that they're on the same surface. And you can see, and this might be surprising to some of you, that if you were older, of white race, ethnicity, or of higher education, that you were actually more likely to bed share. A little bit counterintuitive to a lot of the public health data that we know about. And so what's really nice about this is that sometimes we make assumptions in our head that are incorrect, and so we need data to continue to drive some of the information. This slide shows a study in birth, and this was in 2001, and I consider it a relatively landmark study because it's one of the few studies that kind of looks at hospital behaviors and how that impacts parent behaviors. And so to orient you, first, the little table shows you the parents' report of the position that they witnessed in the hospital. And this was way back when, in 2001, not that long ago for me, but for many of you it seems like a long time ago. 37% said that healthcare professionals put the baby on the back to sleep. That means the majority were using other positions. And there was a lot of side position use, and then a lot of data came out about the side position having twice the risk of sudden infant death syndrome than the back position. So the side position is not okay. And then what they did was they did an analysis looking at odds ratios of what the parents then did with their own children. And you can see here that people had a 4 times likelihood of using the back sleep position if that was a position that they observed in the hospital. So hospital modeling is essential. And I say this all the time to our nurses, our medical students, and our residents. And I cannot tell you how many times I go into a room and there's a big, fluffy, beautiful, fleecy blanket that's about 1.5 inches thick in the crib. And with the pressure of Press Ganey, a lot of the nurses and doctors don't want to say anything because they don't want to upset families. On the other hand, somebody's got to be a bad guy, so that's often me. I go in, I compliment them, I say, it's a beautiful blanket, this is great for carrying, it would work lovely during cold winter days, and you should use it, and I'm so glad that somebody got it for you or that you bought it for yourself or for your baby. However, we don't feel that it's safe to use it in the crib because you can imagine if the baby's face rolled over onto it, how the baby might not be able to breathe through it. So keep this beautiful, wonderful blanket. Please don't use it in the crib while your baby sleeps. It's a hard message, and not everyone receives it well, but I try my best to be nice about it. Okay, and then just one more slide from that student-led study. We looked at back position use in 2012, and though it was a relatively small sample of just under 300, you can see that 93% reported using the back sleep position. So that was really great for me to see as a pediatrician. Again, 15% bed sharing, and then 97% using the back sleep position. Okay. Now, what policies have been put in place in our state to help hospitals do the right thing? Are these mandates necessary? You guys can go home and think about that. So when we think of policy, we think of the carrot and the stick. And the carrot can be incentives or money that's given to hospitals. We like that. That helps us out. Or sometimes there's a stick where somebody says there has to be a law that mandates that all hospitals in Pennsylvania do X, Y, and Z. Now, my understanding, and correct me if I'm wrong, is that we have 3 mandates related to newborns and newborn care in the hospitals. The first one came out around 2002, which was related to shaken baby syndrome. So every single family that leaves a hospital in Pennsylvania must have received information about shaken baby syndrome. Now, pediatricians were already doing this because we knew that's what the American Academy of Pediatrics wanted us to do. We knew it was the right thing. It was evidence-based. But by having a law, then we know that small and large hospitals, independent of resources, are still giving this information. Around that same time, and if anybody knows the date, please help me, because I even talked to nurses with lots of gray hair who could not exactly place the year. There was a hospital information program, car safety, that came out under a title. So it was a little bit different. It wasn't through an act. And that mandated that birthing hospitals talk about safe car seats. And actually, in every hospital, there's car seat inspection by the nurses who receive special training. Those happened around the same time. And then it wasn't until 2010 that there was a mandate to talk about safe sleep. Now, when this first came out, we were all like, ooh, we're being mandated to do things. On the other hand, we weren't really bent out of shape because we were already doing it. We just kind of did it in a more standardized way so that families were signing a form that was created by the State Department of Health. If any of you are interested in this, I think this is really kind of a cool approach to policy and has been very effective, particularly at our hospital, which I can speak for. This next slide gives you an example of how hospitals can be driven to do their own thing. So this is a self-driven initiative. Many people refer to this kind of research as quality improvement projects. And this was basically a study that looked at whether or not people were following AAP recommendations. And what you can see is that on the x-axis, they're looking at time. And so at baseline, they started out saying, in our observations across this hospital multi-collaborative, we found that 32% were following AAP recommendations when they went to each of the hospitals and they looked at every case in this study. And then at the end, what they were very happy to see by having a QI initiative focused on safe sleep was that at the end, 58% were using the AAP recommendations. Now, some people say, well, the AAP recommendations, there's a long list, there's a lot of things that we have to follow, and they focused on a number of things, and what they found was there were more cribs that were relatively empty. And by that, they meant there weren't the fluffy blankets, there weren't pillows, there weren't stuffed animals. And I can tell you, I see all of those in the hospital, even today in 2017. And they also saw that there was a reduction in loose blankets and an increase in education by hospitals. The other thing that hospitals can do is they can look at whether or not they have a policy on safe sleep. And there are a number of items that you can have in your hospital policy. It can be 5 out of the 12 or so that I listed here, or it can be all 12. And if you go to the link that I have shown on the slide, there's a really great policy that was done through the Robert Wood Johnson medical system. It's very, very comprehensive, and I thought it was fabulous. I'm not sure if our hospital would like such a lengthy policy, but I think we could modify what they have there. So if you want to go back, we can go through some of these. We talked about a lot of these: sleep position, bedding. We didn't talk about smoking, drugs, and alcohol so much. Pacifier use. Many of you know that the American Academy of Pediatrics recommends pacifier use as a reduction for sudden infant death syndrome risk. Monitoring devices. It comments on NICUs. I think that sometimes what happens in a neonatal intensive care unit might not be the same as what happens in the late preterm or newborn nursery unit. It also talks about monitoring devices. Tummy time is another great thing that I have to say in the last 5 to 10 years of my practice. I see medical students, residents teaching it all the time. That helps to build the anterior muscles and also reduces the risk of a flattening of the head. They also comment on breastfeeding and then immunizations. This is one of the sketches that's in this particular handout, and this was done in collaboration with First Candle and the National SIDS Alliance. And I really like this diagram, and I think I'm just gonna laminate it and carry it around with me, because I think by having a visual, it's really good for families to understand that we're not just sort of saying, yeah, your baby's gonna be fine, put the baby on the back. That we actually have some evidence, and that anatomically we can kind of map this out for them. So if you just take a look at the diagram, it sort of shows you the position of the trachea, the position of the esophagus, and really it kind of helps families understand that what happens when they're prone is that a lot of things collapse, and that's not necessarily going to be safe for the baby. Okay, and then lastly, I'm wrapping up, I promise. I want to tell you how wonderful it is to work in this great city. I think a lot of times we feel overwhelmed by a lot of the social problems and the public health problems that exist in our city, but we really are one of the greatest cities in America with respect to how much health care we deliver. We've got so many healthcare institutions that educate future physicians, nurses, physical therapists, and so forth, and we have great collaboration across the city. So I've never really come up with an idea where I haven't been able to find great collaborators who are willing to work across institutions. And one example of this is the baby-friendly hospital initiative. So many of you know, sadly, many of the maternity hospitals closed because of lack of resources, and people were very worried about where Philadelphia's babies were going to be born. I'm happy to say that we're stable at 6 hospitals. Hopefully that number will not decrease. And we're all working together to make sure that we're baby-friendly. And this was a breastfeeding initiative. Many of you are familiar. World Health Organization, USA has a baby-friendly program. And in Philadelphia, we're working together to have all hospitals become baby-friendly. And we're sharing. And so it's a little bit competitive because we're like, oh, well, we're doing this, where are you on the pathway? But that little bit of competitiveness keeps people on their toes. And people are really willing to reach out and help people who are kind of behind or who don't have as many resources. And we started to talk about related issues like safe sleep. So I'm hoping that you all will join in and work across institutions and collaborate with others to figure out how we can help one another and learn from one another. And then my last couple of slides, this is just visual images and how important they are. So the good and the bad. There's not the ugly, because babies are cute. But you can see that the good is that with really clear messaging, you can show that a baby can sleep comfortably without blankets in a crib. That doesn't look terribly boring. It's a colorful little jumper. And then on the other side is actually an advertisement by a baby company for these cute little animal fleecy blanket things. And yet I look at that as a pediatrician and I say, that's so horrible, because the baby looks all cute and comfortable, and why wouldn't any parent want to have one of those? And yet it's just not really what would be safe sleep. Okay, simple message, bridge gaps. So in summary, sleep location, sleep environment, bedding, breastfeeding, and then modeling good behaviors. And we all want to work toward a common goal. And then just to conclude, the back sleep position is the #1 modifiable risk factor for SIDS risk reduction. Blacks have twice the risk of using the prone sleep position and twice the risk of having an infant die from SIDS. Hospitals and clinicians have an important role in SIDS risk reduction. Philadelphia hospitals are baby-friendly and working together to keep babies safe and healthy, and simple messages bridge gaps. Thank you very much.
Am I on? Can you hear me? Great, wonderful. Those were great talks. Thank you so much. And thank you all for being here tonight and hanging in there for the third discussion this evening. What I'm going to do tonight is I'm going to talk about same room, different beds, we all sleep better, the story behind the Safe Sleep Philly campaign. I have no disclosures. Tonight our learning objectives will be the following. 1, to recognize the role of the Philadelphia Fetal Infant Mortality Review Team in reducing sleep-related infant mortality. 2, to describe the development of Safe Sleep Philly campaign, share the room, not the bed, better rest for all. And 3, to begin to assess the reach of this campaign and plans to include future cohorts of families and caretakers. So the Philadelphia FEMUR team includes about 20 or more organizations in the city. First, you'll see the 3 Healthy Start programs, which is the Philadelphia Department of Public Health Healthy Start, Einstein Centering Healthy Start, and Maternity Care Coalition. And we come together to be the backbone for the FEMUR. Next, you'll see our partners, Cribs for Kids, including Eileen Tyrala, who is our moderator tonight. You'll see city health, city agencies. The MEO is listed, and Roy Hoffman is our, I might be giving you feedback here, and Roy Hoffman helps us with our FEMUR reviews. We have most of the children, we have both Children's Hospital and most of the delivery hospitals represented, and our MCOs. We are very, very lucky because the Baltimore City Health Department has been our mentor, co-advisor, pal in this process. They have a very effective FEMUR team. They've created very effective campaigns that are city-specific, and they have been very gracious in coming and working with us to expand the efficacy of our FEMUR team. So what is FEMUR? FEMUR is a process by which we identify themes, create recommendations, and take action. So the first, you'll see that a case review team is a set of reviewers who look at the sleep-related infant deaths and in-depth parent interviews to identify themes and make recommendations. These recommendations go to the community action team, and that team translates the recommendations into actions. Now, those actions could be system change, policies, laws, or, in our case, a campaign. So, for example, in 2016-17, which is our first functioning year, we had 3 top safe sleep recommendations that came out of the cases that we reviewed. The first recommendation was that babies should sleep alone. Pretty simple. Second was no bumpers, no pillows, no blankets in the crib, no clutter. And then the third that came out was really interesting, which was parent exhaustion. Parents are exhausted, and that's what's happening in some of these cases. But what we really learned by looking at these cases and by listening to these parents is just how hard parents work to keep their infants safe. They are working so hard. So families talking to our interviewers would talk about 2 out of 3 key behaviors that they would do. So they would explain, so I put the baby on the back, and it was a firm mattress. And I was sure that the baby was on their back, and it was really a firm mattress. Now, I wanted to be sure the baby didn't roll off the bed, so I put some pillows on the side. and then sadly, that child might be suffocated by those pillows. They would say things like, well, I put the baby in their little bassinet, their crib, and they had a little cold, so a little more mucusy. So we took all the clutter out, put the baby in their crib, just the baby in the crib, nothing else, and I put them on the tummy because they weren't feeling well. So here are parents that are thinking so hard about keeping their babies safe. The stories really are, they're truly tragic. And so as a FEMUR team, we really wanted to find a way that, one, we could honor the challenge that parents have, and two, that we could help parents follow kind of the key steps. So with this information, we linked up with the commissioner, who was very committed to decreasing infant mortality and really wanted to create this campaign. So the commissioner led a campaign with all the information we have from FEMUR, and there were a couple tenets. First, the commissioner suggested the campaign image needs to show families what safe sleep really looks like. It can't be theoretical. It can't just be a baby sitting in a crib. How do you actually do that in Philadelphia houses that are pretty small if you live in a row house, have small bedrooms, are pretty compact? How does this actually happen? Two, we need to use data to focus the message on modifiable behaviors that will reduce risks for Philadelphia families. So we couldn't have a campaign that had every single AAP recommendation, although I'll share with you how we included that, because we really wanted to say what's hurting our babies and how can we change that. The commissioner said, keep the message simple. We all agreed that we should celebrate Philadelphia families and we should honor our families. And most campaigns like this work best if they're very local and they resonate with the families who we're aiming to support. And then finally, we wanted to address parents' instinct to protect their infants rather than take a risk. And what's clear about safe sleep deaths is parents are not taking a risk. This is not a risk behavior. This is parents trying to protect their infants and inadvertently not getting all the information, and the child dies. So first, when we did focus groups, we had moms say things like this. This is a 25-year-old mother of a 4-month-old. When I go to bed at night, I want to make sure that she's okay. I worry that something will happen to her while she's sleeping. And the word worry, or I'm afraid, or something could happen came up a lot in our focus groups. So the campaign message, we all sleep better, better rest for all, is part of that same room, different beds. People really wanted to say, if you can create a safe environment, everybody's going to sleep better. We're going to take care of parents so they can do a good job parenting. They can be assured that their child is close by and safe. And so that's a key part of our messaging. Then we wanted to focus on the modifiable risks for Philadelphia infants. So what's really clear in this dark blue part of the pie is that 7 out of 10 babies who die from a sleep-related death in our city are not in a safe sleep environment. So if we can focus on that issue alone, we will be making headway. The other issues are co-sleeping. And then also, we have over half of our infants still being put to sleep on their side or on their stomachs rather than on their back. So we decided in our campaign to focus on sleep place, co-sleeping, and having folks put the baby on the back. So here are our parent cards with the key steps. The message is simple: same room, different beds, better rest for all. Now, these are Philadelphia families. These are the families we serve. We go into their house, we ask them to get into their jammies, we take over their bedroom, and we take pictures. And so here is Tim, trying not to giggle. TT, who is doing her thing, and good old Kennedy, who, before we actually photoshopped it out, had this adorable white bow on her head, but she's not supposed to sleep that way. And then the back of the card has, did you know? So here's the serious part. Did you know? One baby in Philadelphia dies every 12 days because of unsafe sleep. Every step, every time. 1, your baby always sleeps in a pack and play or crib. That pack and play or crib is just for the baby. No bumper, pillows, blankets, or toys. Lay your baby on his or her back. And the idea of the messaging is that as a provider, as a medical student, as a nurse, you can actually say these. This is a directive to somebody without, I think, sounding too bossy. It can, depends on your tone, but it's just really clear. And it doesn't create ambiguity. If one provider says something a little different than another provider, a little different than another provider, sometimes people think the message is different, when in fact the message is the same. So we also have provider cards, and these cards are for nurses, residents, home visitors, DHS workers, KUA workers, anybody who feels that they also want to have all of the AAP guidelines in very simple format. So one side of the card has this, the pictures above, and then the information for the parent is below. And then you flip it over. Please take one when you leave. And we have the other AAP recommendations, and they're super simple. So for example, avoid smoking in your baby's home. Breastfeed if you are able. Once breastfeeding is going well, you can use a pacifier. Immunize your baby on time, etc. So all of these cards hopefully will be driving folks to visit safesleepphilly.org. And we're still building the website, but we will have information about behind the scenes. How is it that you get Philadelphia families to let you come into their home and take pictures and get them set up to sleep and all that kind of jazz? Anybody who needs a pack and play in this city can get a pack and play. So our partners, Maternity Care Coalition, provide pack and plays, and MCFH provides pack and plays. We're in the position to go out to folks' homes to set up the pack and play in their home and to teach the whole family, which is really quite amazing, because then you can get a lot of discussion about resistance and a lot of discussion about choking, as Dr. Chung mentioned. We have additional resources, and one of the resources I want to mention for some of you in the audience is the Commissioners Running Start Health, which is a way to cohesively address early childhood issues. So visit that website to see some of the things that the Commissioner is pulling together for early childhood health. And by the way, we also have sites focused on the other big things that will reduce sleep-related deaths, which include breastfeeding and smoking, etc. So where are you going to see our campaign? Roy and I were just talking about this before that we got going. Hopefully you will see our campaign if you live in Lower North or North Philadelphia. You will see it around City Hall. You may see billboards. You may see bus shelters. So we're doing bus shelters, billboards. You should hear us on the radio, Facebook, Google Ads, delivery hospitals, pediatric offices, and home visiting programs. And if any of you are interested in getting literature, in getting actually us to deliver cards, to deliver provider cards, you just go to the website. You can sign in and request things, and we will send them to you. This is a campaign that, to be effective, needs to go on for several years. So What Baltimore taught us is that there's about at least a 3-year period for you to see a reduction and to see a change in what's normative behavior. And we're asking people to change the way they put their babies to sleep. It's big stuff. And so this norm is going to take a couple years for us to see change. And we'll try to hit on highlights, maybe Mother's Day, infant mortality, Father's Day, maybe Christmas at some point. We'll see. So are we reaching who we want to reach? So when we look at our Facebook performance, what we found is that good old Timothy and TT and Kennedy are taking it away on Facebook. So they have reached about 120,000 folks. 100,000 of those are women, about 20,000 are men, and that's pretty good reach for a campaign that's been out for, at that point, it was out for 3 weeks. So we definitely are making some headway. We are surprised that a picture, which is Tim and the baby, and another one, which is Jasmine, who's one of our spokespeople, are not quite trending as much, but it's, different things will speak to different folks. The idea of doing this is being able to say, what are people wanting to see? What is interesting? Where can we build on these messages? How can we bring different people in and different caretakers in? And the next population that we hope to reach out to are grandparents and caretakers. So I really want to thank you all for your attention tonight. First of all, for being here, for your attention, for the great talks. You met part of our FEMUR team. All of us have worked together, and I just learned even a lot tonight, and I really want to thank you all for being here, and I hope that you can take some of the messages that you have, that we have here and that you've learned tonight, and share them with families and researchers and colleagues, so that we can all be on the same page and working to reduce infant mortality. Thank you very much.
Okay, wow, I think that was a fantastic series of presentations and overview of what's happening here in Philadelphia. Could our 3 presenters join us here on the stage? Here we go. And I do believe there is a microphone. Okay. That will be circulating. So, and I believe I can, there we go. So we'd like to open up the floor for discussion of the presentations you've heard this evening. Go ahead.
Oh, sorry. Good evening. My name is Kamaya Miller. I am a first-year MPH student at Drexel University. I wanted to ask, there is like a baby bed attachment. It's kind of like where the pack and play meets the co-sleeping, like with babies in the bed. It's an attachment. Is there any research on that, like how that impacts SUID or SID?
Could you describe a little bit more?
So it's like a bed that opens up and connects to your mattress. So your baby is like right beside you and not in a completely separate.
Okay.
So I believe it's a co-sleeper.
Yeah.
And so there are some of those products that are not approved by the juvenile products industry, and some that are. The tricky thing that we find with products like that is that some of them are more apt to be recalled over time than others. So what we've tried to do is, one, to make recommendations that are approved by the juvenile products industry that have been tested, consumer agency, we know that they're safe, and then focus on products that haven't been frequently recalled. So for the city, when we're offering folks a safe sleep environment, we like to offer a pack and play. That's an environment that works from 0, when the baby's little, up to almost 1 year of age for most of our babies. So it gets them through the high-risk period. And other products, we've had different, there's been different support for those and different reliability. So I know people use them. Many people who breastfeed use them. I've got to tell you, that's a favorite of women physicians, but it's not something in our city that we tend to offer at this point.
Thank you.
Thank you.
Hi, my name is Paige. I'm also a first-year student in the MPH program. So we see a lot of people citing about not putting their babies on their backs due to fear of asphyxiation. Is there a way we can mediate that fear, maybe sort of debunk some myths about it?
I think you can. I mean, education, showing the picture that Dr. Chung showed in her presentation, that graphic that shows where the trachea is to the esophagus. If you want, you can also quote me to say that in the last 10 years that I know of, there hasn't been a single infant who has ever died of choking to death while in a crib. It just doesn't happen.
Right. On a historical note on that question, when we first started the Back to Sleep campaign, actually the pediatric gastroenterologists were very concerned that we were going to see a major increase in the incidence of aspiration events in infants in this country, and it never happened. So even the North American Association of Gastroenterology and the European Association of Pediatric Gastroenterology still say, even with children with reflux, because I get that all the time, and reflux can be that your baby spits a little bit and everybody says that their baby has reflux, that it is still safer to put the baby on the back than in any other position, regardless of what the health condition of the baby is. The back is best, unless there's some really extreme congenital anomaly or circumstance.
And then can I just add that our home visitors take out the picture that Dr. Chung showed, and especially for grandmoms are particularly worried about that. And so of all the pieces of information we take out, that's the one that appears to make most sense to people, because it doesn't make sense any other way. The adult, and we say babies are made differently than adults. So for adult, you're right. Before a baby, this is how they're made. It's different, and then you show pictures.
Thank you.
The only other thing I might add is that reflux in the newborn is really common, and I don't think parents recognize how common it is. And that, in combination with the graphs that show the decline in SIDS rates as we've declined in prone sleep position, I think the two can be very convincing along with the schematic.
Thank you.
Good evening. My name is Donald Carter, and while I'm not a healthcare professional, my brother's a doctor, so I get a lot of pushback. But I've been on the board of Philadelphia Fight. If you're familiar, well, of course, we've done a lot of programs here, and fortunately, I've just been rolled off of the board 14 years. I'm just so grateful. But my question is, in one of the pictures, the little girl has one of those lovely little headbands in the crib. Would you consider that a possible choking thing?
We actually photoshopped it out. So the family was so excited to have us come, and they were so excited to put that on her that we felt like we just, people have, it is hard to have someone come into your bedroom and take pictures. And so we just went with it and explained and taught and all that kind of stuff. By the way, Kennedy wasn't sleeping in those pictures. She's like wide awake because the camera's going. It's hard to get the baby sleeping. But yeah, that would have been a choking hazard. And so we definitely didn't want to do teaching intriguing pictures that showed that. But yeah, so we definitely educated about that, and the family was really dressing her up for the show. But thank you for mentioning that.
And concomitant to that, your cards, do you have, I see that Concilio is part of in the FIMR group of facilities. Concilio is included. Do you have bilingual cards, and do you do that kind of outreach? Because we certainly at FIGHT, especially through the TEACH programs and the peer-to-peer, it's necessary.
Absolutely. So what we will do is the Spanish cards should be printed next week, and then we try to take the top 10 languages that are spoken in the city, and then we will make cards in those languages so that it's available for folks who are not primarily English speakers.
I'm always surprised when I get communications from city or state of agencies and organizations, and it's in Cambodian and Thai, and I'm thinking, yeah, those languages are necessary in a multi-glot city like Philadelphia. So thank you.
Thank you. Thank you.
Hi, I'm Kate Fox. I'm wondering if you could speak just a little bit more about the social justice piece and what contributes. Is that, and maybe specifically in Philadelphia, is that education in the delivery hospitals, or maybe limited access to prenatal care leading up to the delivery, or?
Yeah, I mean, it's a big issue and a daily issue in the hospital setting. It can be very challenging because sometimes the people who need the information most may not get the information. They may not be as forthright with asking questions. They may not want to speak to the healthcare professionals, and so I find myself constantly reminding people that actually the biggest bang for the buck is to help the most underserved families. And that's been shown over and over again through public health information campaigns, that the odds ratio just kind of shoots up for the high-risk populations. I think there are a lot of advocacy initiatives that we can do to kind of bring to policymakers' attention that there is a disparity related to education, income, and race, ethnicity. Because that is all preventable and modifiable for sure. Was there anything specific that you wanted to have me touch on there?
Oh no, that was a good overview. I'm wondering if this Safe Sleep campaign in Philadelphia is specifically addressing some of those challenges.
So we're addressing those challenges in part by how we chose to do some of the pictures, and we are in real people's homes throughout parts of the city that have the highest sleep-related infant mortality rate. So it's demonstratively showing folks how we can do things differently. And then we've actually rolled out the campaign into some of the highest risk areas. Having said that, we really also want it to be for all people in Philadelphia, and we want all babies to benefit from sleeping this way, and to be honest with you, for parents to benefit from sleeping safely and getting the sleep they need. Co-sleeping is not where parents sleep their best. So while we want to focus on the disparity, we also want to be sure that everybody in the city feels they can benefit.
The one other thing I want to add is, like, how do people get information? And so when I was a resident, we were actually recommending the prone sleep position. That's how old I am. And so you have to kind of remember that grandmothers heard that message straight from the mouths of the nurses and the doctors who were serving them. And not all of them access the same media resources that we do, and so they may not be up to date with current information. So I think that's just something to remember. We're not blaming grandmothers. We're not kind of trying to make them the enemy. And I actually try to engage grandmothers in the conversation for sure.
Hi, I'm Nick Salter. I am a first-year MPH student at Jefferson, and I wanted to know if there's any data on the difference of sleep-related deaths for different neighborhoods in Philadelphia, and if so, are you ramping up your campaigns towards kind of the more the more prone areas for this topic?
The short answer to that is yes. I mean, we do map it out. There are relatively small numbers overall for the city, but as one of the slides I showed was with the neighborhood income quartiles. So we do know where they're happening more frequently, and I think part of your campaign, I assume, is targeting those neighborhoods that have a higher incidence of these deaths.
Yep. And we'll also be looking at who requests, what neighborhoods people live in where they request a pack and play. And so far, it's been the very breast estimate pretty concordant with areas that we would expect folks would need that kind of help.
Sarah, you had mentioned North Philadelphia, but what about in the earlier data? I think Southwest Philadelphia was also heavily represented. Are we doing concentration there?
Yeah, so there is, we in the Southwest, there's more. The tricky thing is some of the campaign, where we can put our campaign depends on what resources are available in a community.
Gotcha.
So lower north and north, we can use billboards more, and we could use some of the bus stops. It becomes a little more sparse in other neighborhoods. So in those neighborhoods, we really push for the pediatricians and for all the delivery hospitals to be sending out these messages, and for the home visitors in those neighborhoods as well.
Okay, thank you.
Excellent, thank you.
I'm Jim Bueller from Drexel Public Health. I'm also the chair of the section on public health and preventive medicine. In that capacity, I'd like to say how absolutely delighted I am that so many of the people that have stood at this microphone have introduced themselves as a first-year public health student. And welcome to the public health community in Philadelphia. And I hope that you continue to become active members of that community. So I had two quick questions. A number of the pie charts that you showed had a sizable percentage of the babies who died that didn't have the risk factor in question. And I'm wondering if you look across all of those together, how many don't have one of the risk factors that you pointed to. And then my second question related to grandparents that you touched on. I think back to sleep has probably been around long enough that many grandparents, though clearly not all, would have heard the back to sleep message, but some of the other messages, particularly about things in the bed, are newer. And most of the focus groups and conversations that you've had have been with parents. As you look ahead to a campaign that's also focused on the grandparents, who are often a big influence, or who have the babies when the parents need a break, how are you going to learn about the grandparents' thoughts and attitudes?
That's great. Do you want to
I'll do
take
the first part?
Yeah.
Okay. So the first part of your question about how many of these families don't have any of the risk factors, well, we do have a fair number who don't have any reported risk factor. And it's, also what I can tell is that people, they see, I'm not a forensic pathologist, I'm a pediatrician and a public health practitioner, so I don't do the autopsies, but I've been doing this for many years, and I work with the pathologists at the MEO. And contrary to what may be depicted on television and movies, it's not, and I haven't seen these shows, but I get the impression that they give the impression that you can say, oh no, this baby was staying here and then they moved over to their side at this time and this happened. It's not that precise. And so much, of these infants who are dying, there aren't always physical manifestations that show what happened. And oftentimes what the medical examiner office is left with the investigators and the pathologists is based on the history of the parents. And I've seen many times where the good news is, what people are doing at home. I think the message is getting out there that people know what the right answer is. As you showed with the studies, they know what the right answer is to give to the doctor. When you come see a doctor, if you're a smoker, maybe, and they ask if you're smoking, maybe they may not, the patient may not give the honest answer, but they know what the right answer is that the doctor wants to hear. We've seen before, and I've talked to the investigators, where they'll go into households and say, well, where was the baby sleeping? They say, oh, sleeping in their pack and play. And then the investigator goes to take pictures to see where's the pack and play. Oh, here, and there's like tons of clothes and folded, unfolded laundry in there. And then luckily, sometimes the investigator will press them and say, well, it doesn't seem to me that anyone has been sleeping here the last couple of days. And say, oh, well, okay, well, they normally sleep in there, but they were sick, and so I brought them into bed with me that night. And so We're getting a lot of times the socially acceptable answers when the baby dies, because also a lot of these families have other young children in their households. They don't know what the laws are. They think that DHS is going to swoop in and take away their 1.5-year-old just because they slept in bed with their baby and the baby was found dead. That's not the case. But so we don't always get the honest answer. So our answers are limited sometimes to what the families tell us. And then there is still the, what we call SIDS, sudden infant death syndrome, where, maybe seems like they're doing everything properly, and despite everything, autopsy, investigation, toxicology, we just don't know it, but we're calling it SIDS, this syndrome, which really doesn't have a known causal factor.
As far as the grandmothers, I was thinking about
Or grandparents, fathers.
Grandparents. Think about an article that we all read recently in Pediatrics where, moms were able to say that their intentions weren't the strongest factor in how a child slept. It really was other folks in the family who are making those decisions. Interestingly, when we did focus groups with grandmothers, they gave a very socially normative answer. And our kids should be doing the right thing, etc. So it really wasn't particularly as helpful as I thought it would be. What's been much more helpful is to go into a home where it's multi-generational and have the different generations give pushback. And one of the pieces of pushback is, you pediatricians are always changing your recommendations. Why should I believe you this time? And, when Esther says, we were residents, babies were sleeping on their tummies, and we thought it was a good sign. You go by a baby's bed, they'd be like rolled up, a little button area, like, yeah, healthy baby, and we keep moving. So, I think it gives us a lot of empathy about why this is so difficult for families to change, and that just a quick recommendation is gonna, I understand why you'd blow off a quick recommendation. So we really need to be talking to families and explaining things. The visual, I think it's interesting to me that the visual is interesting to grandparents. I didn't think it would be. So I think we'll have to study that a little more. And if any of you are looking for master's projects, there we go. Come see me.
That'd be when they're second-year students, right?
Hi there, my name is Nico. I'm a volunteer with the National Health Corps, and I guess my question would apply more to Dr. Kinsman. I guess I was just curious about how recommendations wind up on products that families of newborn babies might be purchasing, because I've seen like choking hazard things, and I guess I was wondering what it takes to get the recommendations that you outlined onto these types of products.
That's a tricky one. Do you guys want to take that one?
Yeah.
So,
I think it takes a lot
Yes.
to get warning labels on products, because products are for-profit companies that make a lot of money, and it's very hard to regulate and tell them what to do. I do think that we can refer patients and families to Consumer Product Safety Commission website. You can pretty much look up any product. I think clinicians need to be educated about warnings and alerts that have come up. I thought that was a great story that Dr. Hoffman said about that carrier where they made a report to Consumer Product Safety Commission, and then they saw that there was more than just one blip. There were a couple blips, and then they removed the product from the market.
Yeah, I write a Ask the Pediatrician column on the Cribs for Kids website, and I get asked about all of the products, and I'm just amazed at what's out there. And one of the basic assumptions is, well, if it's not safe, how is it that it's being sold? And I can come up frequently with a million reasons why X, Y, or Z isn't safe, or isn't ideal, or whether perhaps you could make a better choice. But we always, if there are certain products, such as cribs, and now the new recommendations for slings that will go into effect in 2018, And each year there are new specific mandates that the Consumer Product Safety Commission comes out with, and then get picked up by the Juvenile Products Manufacturers Association, and then it will get their label that we're certifying it, that it's good, and it meets all the CPSC standards. So those are good things, but there's a million other things out there that never make it that far.
Okay.
Right, and just to add to that, so the femur, one of our first goals, because one of the first cases we reviewed involved a bumper, and so we talked to Josh Sharfstein, who was the Commissioner of Maryland, Commissioner of Baltimore, and worked for the FDA about whether we could, that was how we really started working together, whether we could ban the sale of bumpers in the city of Philadelphia. Knowing that we probably couldn't ban folks from sending it in, et cetera. And so we went through how Maryland had done it, how Chicago had done it, and the reality is that the juvenile products industry lawyers are based officially in across the river in Camden or Cherry Hill, but the office is at 15th and Market. And so we're pretty much realized, and they have started to get pretty savvy about how to fight jurisdictions that want to make that a goal, but I think it's something that we need to keep thinking about, and the question is whether locally you can put a warning label on a product. So locally you can put a high salt label on something, and so is there a way that we can locally say when somebody buys one of these blankets, because that's one of the things that most of the newborn nursery directors are talking about, warning, this is for a baby after 1 year of age, something like that. So I think that's something that we need to really think about as an adjunct to education, is really changing that.
Okay. Thank you.
Hi, my name is Brittany. I'm a second-year pediatrics resident at Einstein. So, over the last 2 or 3 months, we've had 2 SIDS deaths, and we've had multiple close calls when we're at inpatient at St. Christopher's with babies that were co-sleeping or close near suffocation, and it's been really tough. Yeah. In addition, one of the ED residents at Einstein contacted the pediatrics department to see if we could do like a QI project or some type of the next step thing in terms of discharging babies from the nursery, because we do a whole song and dance, and it kind of goes in one ear out the other, and then they're given so much information. So I guess I have a 2-part question. The first part is, what do you think the next step is after we distribute all of this information constantly, and people are kind of either just tossing it or glossing over it? And the second question is, or comment is, do you think that kind of provoking fear in these people would be beneficial, such as, the smoking campaigns on TV with, the people with the trachs and coughing up their lungs, or like Surgeon General's warning on cigarettes? Like, would that be effective?
Do you want to take the cluster first? Yeah.
Sure. So first, let me talk about just that cluster you mentioned at Einstein and St. Chris. In medicine, people who go through medicine, also training, will realize that oftentimes things do happen in clusters. And so first, I can give reassurance that our rate for sleep-related infant deaths is roughly the same as it was this year, which is lower than it was in the early 2000s. And things do happen in clusters. And when that happened, I also looked into it, and I have all the numbers at my disposal to see that nothing has changed, just to reassure everyone. But also, as a side, as part I did in my presentation, I think is also the perception of public health people and other providers that, I work with the numbers and with the reviews, and to say people don't realize the relative risks out there and what is really killing our kids. It's not, all these public health things are important. Fire prevention, motor vehicle crashes, all those things extremely important. We have to keep on educating families and doing outreach, but also what I want to impress upon everyone here is that sleep-related infant deaths is one of the largest largest killers, and perhaps the largest preventable killer of children in Philadelphia. And if anything, and it's awful, and I know when I was doing my pediatric residency, I never saw one, but I can't imagine to be there working, you know, I supervise social workers who work with the families. I can't imagine doing that work, working with a family who had a baby who was expected to live a long, healthy life, and then they're making plans on what's going to happen, this and that, and then they just die suddenly, unexpectedly, and then they're gone. So I think it's, you know, I'll let you deal with the next steps, but I think it's important for you and everyone else here to learn that this is a major killer, especially here in Philadelphia, of our children, especially our infants. So I'll let you deal with the other part.
Yeah. So there are some campaigns. Milwaukee has a pretty famous campaign where they had a baby in an adult bed and a butcher knife. And another campaign shows a baby coffin, and you know, if you sleep with your baby, this will happen. The tricky thing is that what we understand about campaigns that have worked is that they do highlight that this is serious, that a baby could die from this. But parents' fear is already pretty high. And so if you elevate the fear even more, you could potentially increase that urge that parents have to have their baby close to them. That's a pretty strong urge. And so what we had learned from our interviewed femur cases, we had learned from our colleagues, is to empathize with families and the challenge. And it is really hard to do safe sleep. I love the QI graph at the hospital. They're really cranking on that QI graph, and only 60% are safe sleeping. This is not actually the easiest behavior to do perfectly every single time. So I think empathizing with families is really important. I think meeting them where they are is important. Obviously, it's serious. That's not an issue. And that's why the family's asked to keep once every 12 days, a baby dies from safe sleep. But we had another way of putting it is that every year we lose a kindergarten class to safe sleep in our city. And they preferred the one every 12 days, which was great because it's very clear. But I think if you make people feel even more unable to protect their children, you create a different risk. So that's why
I think there's another part of it as well, because that was the Milwaukee one was the fear campaign, but what Baltimore did was one of their basic ways of getting through to parents, and they have had some dramatic results, whether it's all due to this or not. You know, these testimonials from parents, powerful. This happened to me. I never thought it could happen to me. This is what I did. Don't do this. That kind of. They're tearjerkers, and they play them while people are waiting for jury duty. They play them everywhere possible.
And we use them for our centering pregnancy groups.
Yeah.
And I would really recommend you go to the Baltimore website, and the woman who I showed a quick picture quickly up there was their spokesperson, right. And she lost a baby.
Okay. All of those Baltimore, little plug for Cribs for Kids, you can download the Cribs for Kids app, and under media, you'll find all those videos that the Baltimore campaign has with the more powerful testimonials from moms. I find them incredibly powerful.
Yeah, back in January, when I was in the emergency room at St. Christopher's, we had a SIDS death, and I was there for the code and everything, and I actually tell patients that story, and it stays with them, it really does, but I can't, my story can't reach everyone, and not everyone had the same experience, so that might actually be.
As a pediatric resident, one thing that you can do during your clinic, your primary care clinic, is you talk, everyone is telling you asking you all these things to talk about during the quick visit you have, and to do everything you have. If you want to put your money where the deaths are, make sure you talk about, where is this baby sleeping at night, and ask them, and then work on developing a way to provide a message, and maybe, how, we all develop our spiels over time, like to do, if you have to be somewhat confrontational, take out the thing, but in a way that's not as confrontational, that hopefully helps the family listen to the message and say, well, research has shown that a baby is safest when it sleeps alone in his own bassinet crib, placed on his back, developing that message, and that's something that you can do already yourself right now. And it's a multi-factorial, multi-pronged approach to educating the thing, and everyone in this audience can do something, whether even just educating a friend or someone who's a new parent.
But I think it really has to come from your core. You have to attend sessions like this, keep yourself educated, and you have to really believe it. Because when we see the numbers of 42 to 45 babies, that means that many, many families have never met a family who have been affected by sudden infant death syndrome. Right. The opioid epidemic, everybody is affected. But I think that can be the challenge. And even with immunizations, I've seen a lot of the immunization preventable diseases because of time. But more and more, I find that residents and students haven't seen those diseases, so they can't actually convincingly say your baby should get this vaccine. But now that you've been here, so thanks for attending, just by turning the other way, people are condoning behaviors. So if you don't speak up when you see an inappropriate crib setting, that's the same thing as basically saying that what they're doing is fine and safe.
So we have two more questioners in line, and we're going to take those last two, and then we're going to go to our reception.
Thanks. My name's Mary Wilby. I'm a nurse practitioner for a long time, and I'm also an MPH student at LaSalle University. And I guess this is a two-part question. So I'm sitting here with feeling the draft, deep, cool air with my jacket on, thinking about low-income families who, now that the weather's starting to get cold, do you see more of an increase in deaths over the cold winter months when people may be co-sleeping, putting blankets and other stuff in the crib to keep the babies warm? And are there any resources available for families who need the help to keep warm so they're not doing the wrong thing for their babies?
I can tell you from Philadelphia data, and you might know national data better, but it's not such clear-cut, definite spike in a certain time. There's a lot of anecdotal thing. People sometimes tend to say one thing or another, but
in the last 5 years, we looked at this recently, in the last 5 years, we had spikes in November and June. And we think maybe viruses were happening, but...
Or kids are sick, and then parents are bringing the child into bed with them to keep an eye on them and inadvertently placing themselves in a riskier environment. There's no clear-cut answer, but definitely, I think also nationally with like Native American in wintertime, like overbundling, those are risk factors. But, we have relatively smaller numbers and have anything that clearly states it. But as far as with resources for family, I mean, like LIHEAP is like, what's it stand for again? But for the heating,
heating assistance and it's one of the most important things
turn off their
in the
power.
winter.
Yeah.
Right. Yeah.
But babies need to be dressed sort of like the adults maybe want, like you don't want to overbundle them. And so if, like the onesies, and the sleep sacks, to make them warmer and hopefully they have heat in their home, but I think, PGW can't turn off the heat during the winter time, and those are the resources, and educating them that you don't need. I see kids who are overbundled in the summertime, the heat rash, and like, so it's education also in that sense.
Okay. I think your point is great, though, because I think we make a lot of assumptions about how families live and what parents are thinking. And I think if we just ask the question, how's the temperature in your home? What does that mean for how your baby is sleeping in the crib? So I think that's a great point. So thanks for that.
Okay, and last but not least.
Thank you all for this evening's presentation. And my name's Jillian Bird. I'm the nurse coordinator at the maternal addiction treatment program at Jefferson. I think a lot about our women. They are many times homeless. They are definitely low income. And I'm wondering, just in my experience with very little prenatal care and very disorganized, they don't often get to their pediatric appointments. Are you thinking about reaching out to other agencies, for example, welfare? They spend a lot of time at these offices, or shelters to educate. And also the idea of having pack-and-plays available is wonderful, but I am always thinking about alternatives to what if they can't carry the pack-and-play with them when they're going somewhere, or just providing insight into that. And I'm even thinking about psychiatry or providers that are outside of the pediatric arena. Our women are on psychiatric medications, which are dulling their senses to anxiety, to alert them to an issue, and it's just very concerning. But I'm wondering if these thoughts are there plans in place to reach out beyond the pediatric population, beyond the buses and billboards.
As a result of some of the cases that we reviewed in FEMUR, Robin Holtz and Annette Frazier are here and have started to go to addiction places where women who have young children or who are pregnant are being treated. And they're great settings because you have a whole bunch of women from different ages and different socioeconomic experiences who are all suffering and trying to manage addiction. And so it's actually been a great opportunity for outreach, and the circumstances are really challenging, as you say, for folks, because they can be unexpectedly homeless. They can quickly have to move to another part of the state for a while. So we'd love to talk to you about how to be more effective in meeting those needs, because clearly this message and how to take care of children and how to keep them safe resonates so strongly with the folks that we've spoken to. So we would love to be able to talk to you more about that. I think that'd be great.
Yeah, thank you.
Okay, so thank you very much. So I'm thrilled that the questioning session went on this long. That's fantastic. But we'd invite you to join us in the adjoining room in the back there for a reception, and remind you of the next grand rounds that we'd all hope you can attend here. Thank you.